Okay, I have 12 o'clock. Hello, and thank you for joining us for today's Pediatric Mental Health Echo, a session on legalized or not, the impact of THC on the adolescent brain. Before we begin, I will go over a few housekeeping items, and then Thad will take over and introduce himself, and we can get started. But first, we'd like you to type your name, credentials, email, and facility name in the chat box so we can keep track of everyone in attendance. As part of participation in this echo session, we ask that you have your cameras turned on in order to build a more engaging community of practice. Please remember to mute your audio when you're not speaking. Asking questions. When wanting to ask a questions, you have two options. Unmute and ask the question, or if you don't want to interrupt to ask, you can utilize the chat feature to ask your question, and I will check out those questions and ask them as we have a chance. In a bit, I will share the link for the pre-test in the chat, and towards the end of the session, there will be a post-test and evaluation in the chat also. Following the session, you will also receive an email that contains the link to the evaluation and the slides that were presented today. In order to receive continuing education credit for this session, you must complete the evaluation. So I will turn it over to Thad here.
All right. Well, thank you so much for that warm introduction and good afternoon, everyone. I'm excited to be back. I had the privilege of speaking to this group about this time last year, and so it's wonderful to be back. And I just want to thank each of you for taking some time, probably your lunch hour, to learn a little bit more about what I care about, what I'm really passionate about, and that is cannabis. And it's kind of a weird thing to say out loud that I'm passionate and care about cannabis, but it's been something I've been interested in for some time. And so I'm going to go ahead and share my screen, and then we'll kind of get into it as we learned. I welcome questions. I want this to be fairly informal. There's not very many of us, at least on the live call here today. And so I welcome real-time questions, and to keep in mind, they'll save some time at the end to open up the floor for questions. But my goal with this hour is to kind of share content for about half of it, and then to kind of more engage in a interactive conversation about what to do with this information and how we can leverage it in the work that we do with the people that we serve. So excellent. Here we go. I'm going to pull up my PowerPoint. Hopefully you all can see that. Let me put it into full screen. Awesome. So hopefully you can see this as I've introduced it. For those I haven't had the opportunity to meet, I'm Thad. I'm an associate professor down at Minnesota State University, Mankato. Go Mavericks. I've been on the dark side of academia now. This is my 10th year. Prior to becoming an academic, I was like many of you all and practiced in our communities as a behavioral health provider. People often wonder why I'm interested in cannabis, like what brought me to that. Was it my own experience with cannabis, my own use? And frankly, it was understanding or learning from young people just how misguided and misunderstood they were about this psychoactive chemical. And so I've kind of made it one of my academic and research priorities to stop the spread of misinformation, which is kind of a buzzword in this political climate, and really focus in on like what are the facts about cannabis? What do we actually know? What do we not know? And try to weed through a lot of the opinions that come from cannabis. I think it's important to kind of start with my bias. People want to often know, do I support legalization? Am I against legalization? And I don't really feel strong either way. What I do feel strong about is that science should guide the conversation and not political science, which has been traditionally guiding this conversation in the states that have decriminalized and recreationalized cannabis, which I just learned that you all in North Dakota are up again, deciding whether or not that's something that you want to do in this upcoming election. So just very briefly here, I have nothing to disclose. We're not going to be talking about cannabis today as a therapeutic, but rather as a recreational drug. And it's important for me to share as well that the information today is simply my opinion, based in fact, but not on behalf of any of the organizations that I represent. I have the privilege of being on my licensing board, a governor's appointment to that. So it's definitely not the opinion of my licensing board or any of the other boards that I get to serve on. It's just me. today talking. Crazy Professor Thad. So what are we going to do? We don't have a ton of time. I mean, this is a topic that I could literally spend a whole semester talking about. And if you're interested, you can take my class here in the spring. But we don't have that time. We got about 35 minutes or so to really get through the content. And so what are we going to do? We're just going to talk big picture. Why is this a problem? What do we know about adolescent use trends? And then specifically, what happens when tetrahydrocannabinol is introduced to the developing brain, and why are we so concerned about it? And then we kind of end with some prevention strategies, because at the end of the day, that's the goal: is how do we get fewer adolescents and young adults using and abusing cannabis? And then I have a case study, kind of an interactive case study, so that we can kind of engage in some dialogue about the best way to enact some of the information. But ultimately, today's just about to give you some information to help you in the work that you do. You all come from different perspectives. We have nursing, we have prescribers, we have mental health professionals on the call today. And so I'm trying to just have it appeal to all of you and the work that you might do. So what is marijuana, right? So it's a plant, right? It's a plant that grows, and really the only thing, or one of the things that we care about within that plant, are the psychoactive molecules, which most people are kind of blown away to realize that there are over 113 psychoactive molecules that we know of within the various strains of cannabis. But the one psychoactive molecule that gets all the attention is what we shorthand call THC, but stands for tetrahydrocannabinol delta 9. And cannabis is unique in that it gets its own drug classification. So when you think about how we classify drugs, we usually think of them as stimulants, depressants, hallucinogens, opioids. And marijuana doesn't fit nicely in any of those boxes. And so we just give it its own classification because of how unique it is, in the effects that it's having on the brain, and then what the effects of that drug are. So it gets its own drug classification. You can't have a conversation about marijuana today without just briefly looking at history. I think one thing we don't do very well in this country is think back throughout history, and learn from what we have done previously. And so marijuana in this country has had a very interesting history. So if we just went back 124 years at the turn of the 20th century, coming into the 1900s, the federal government didn't have any laws around psychoactive drugs, right? So it wasn't that long ago that the pendulum of how much we cared about psychoactive drugs was all the way on one side of the room, this kind of laissez-faire, live and let live. But over time, that pendulum has swung from we don't care at all to we care so much about psychoactive drugs that we incarcerate more people per capita than any other country on the planet. So we went from not caring to caring a whole lot. And there's a whole presentation I could do about the reasons why we've cared so much. I don't have time for that today, but cannabis was a part of that conversation. And ultimately, in 1970, when the federal government decided that we care so much about psychoactive drugs that we're going to criminalize some of them, that they established the Drug Enforcement Agency. And the DEA's first task was to put drugs in a hierarchy. Which drugs are the really bad drugs, and which drugs are the least bad drugs on our streets? And we refer to that as the DEA Schedule of Controlled Substances. And so residing on Schedule 1 as of August, 15th, 16th today, 2024, cannabis, marijuana, is still on Schedule 1 of the controlled substances. And so that means it's one of the worst drugs in the eyes of the federal government. We did, however, this summer receive word that the Department of Justice, at the behest of President Biden, has reclassified and rescheduled marijuana to now a Schedule 3 drug. But there's a process that has to happen in order for that official move to take place. But we have had a very different and difficult history with marijuana, and now we've turned it over for the most parts to individual states to decide whether it should be legal and whether we should use it therapeutically. And so as of today, there are 24 states, almost half of our country, that has decriminalized and legalized recreational use of marijuana. 38 states have approved its use as a therapeutic. So you can see kind of where the majority of you all, I'm assuming most of you are calling in today from North Dakota, but you're kind of surrounded on the east and west side of you with states that have decriminalized it for recreational use. South Dakota voted to, but their governor then squashed that. But it's simply a matter of time before more of that dark green just kind of populates throughout this country. So, what do we know about the amount of young people using this substance? So it's important from my perspective, it's important to understand what are the drug use trends, like meaning how big of a problem is this? You notice we're not having a presentation today on the adolescent abuse of LSD. It isn't warranted. We don't have a problem with adolescents abusing LSD. We may in the future, but currently we don't see that drug trend. But when we look at drug trends across this country, there is one drug in particular that has started to increase and an increase year over year. It's quite interesting, actually, that most drug use statistics remain static. They don't change very much year over year. The one exception to that has been cannabis, that we have started to see a slow progression and increase year over year with cannabis use among adolescents and young adults. And so when we look at the national trends, so this is data. Sorry, this is data pulled from Monitoring the Future, which is a National Institutes of Health funded study that's housed in the University of Michigan. So it's considered the Cadillac of like drug trend studies among adolescents and young adults. And so every year they're out there surveying students and young adults from the East Coast to the West Coast, North and South, to really kind of get a pulse of what's going on with young people. And we see here with marijuana, we saw another bump in the amount of young people who are using marijuana. So every year we start to tick up a little bit more, where you can now see that with our 12th graders in 2023, that almost 30% of them have expressed using cannabis at least once. So this is kind of the annual prevalence. So more than experimentation, but less than what we would consider regular use. What's been really interesting, one data point as a researcher that I wanted to point out was that for the very first time across any psychoactive drug in the history of Monitoring the Future, we have seen that female identifying young people are using a psychoactive drug at greater rates than their male identifying counterparts. Like that just has never happened. Doesn't, whether it's alcohol or prescription drugs, it has always been more male identifying students who are using drugs at higher rates. But for the very first time, as you can see there with that graph, you are seeing more females using cannabis, or at least trying cannabis, than men. So I want to turn it over to you. Like, why do you think, not just the female like specific, but just why do you think year over year nationally we are seeing an increase of cannabis use? So you can either, yeah, why don't we just have you put it in the chat if you have some hypotheses as to why this increase is occurring. Or you can unmute. There's not that many of us. If you want to unmute and share, I just want to get your thoughts. What do you think has led to this increase of cannabis use? Thoughts that it's safer than alcohol and other drugs? That's a great one, Abby. Thanks for kicking it off. Anything else? I know it's lunchtime. You're probably watching this with a sandwich in your hand and don't really want to either unmute or type in, but that's okay. All of us probably have some hypothesis in our brain as to like why we are seeing this increase, right? And so Abby touched on what I would consider the number one reason, which we'll get into here. But ultimately, through my research, I've identified kind of three reasons why we've seen this increase nationally. One is accessibility. Anytime a drug becomes accessible or more accessible, it tends to lend to an increased use. And we can see that across every state that has legalized cannabis and made it more accessible, that we've seen an increase in use. So I'm not naive. I absolutely understand that high school kids in states where it's still illegal can get pot, right? Like I understand that it's not this drug that is only available in these dispensaries. But when you have retail sales of a drug, when you do make it more accessible, you are going to see that increase. So accessibility is reason number one. Number two is it has to be socially acceptable to use the drug. So you have to have a culture of acceptance for people to say, I will self-select into using that drug. And other than alcohol, there's no other psychoactive drug that we glamorize and romanticize more than cannabis. Right. So alcohol wins. We have like commercials on our TV that glamorize its usage. But with cannabis, we have a whole like media set that says, you know, cannabis isn't that bad. It's not only not that bad, but it's okay. It's cool to use. It's trendy to use. I think about the movies I watched in college and even the television shows. I'm probably dating myself, but movies like Dazed and Confused, and we had that Weeds show that everybody kind of fell in love with for a while, and that told one narrative of this drug. It kind of told the narrative that it was socially acceptable to use this drug. People often wonder why kids don't smoke cigarettes anymore, right? Like, because kids don't smoke cigarettes. And they often think, well, it's like, well, we made them too expensive or we made them too inaccessible by raising the age to 21 to purchase them. And we told kids that they're bad for them. None of that is true. The reason why kids don't smoke cigarettes anymore is because it's not cool. In fact, it's the opposite of cool. It is gross, and you don't want to be a gross kid. And so nobody smokes cigarettes because it's culturally unacceptable. That's the number one reason. With marijuana, we've gone the other way. It is culturally acceptable. It is trendy. But the number one reason, as Abby indicated, and you probably already knew, is that people believe the drug is safe. Particularly young people believe the drug is safe. So there's a phenomenon in drug research that people like me are interested in. It's called risk perception or perception of risk. So when you think about what predicts a young person in using a drug, you have to have accessibility, you have to have a positive culture, but you also have to have a low perception of risk. So the young person has to believe that the use of this drug is not going to have potentially fatal or negative health consequences. And the lower the risk perception, the greater the likelihood that individual will at least try that drug, if not use it regularly. So the belief that this drug is safe is by far and away the number one reason why we've seen this increase, and we will continue to see this increase until we can correct the narrative about the safety threshold of this drug. So you can see on that graph there, that's a bit of a dated graph, but it makes the point in that you can see the peak of the risk perception was kind of like Ronald Reagan, war on drugs, just say no days, right? Like we hammered into kids how bad drugs were. And then over time, you've seen that number have this precipitous drop where now, much fewer kids and adolescents and young adults believe there is risk or certainly great risk in using. And I'm going to show you a stat next about North Dakota specific. But in my work, it's like, okay, we can see the numbers, but I want to understand, like my research has been on like why, like where is this belief originating from? Because once we understand that, then we can have actual prevention to target those reasons why they think the drug is safe. The problem is these aren't like these are true. The reasons they believe the drug is safe are actually true reasons. So number one, it's legal. Now I get it's not legal in North Dakota yet, but this idea that something is legal has led to this belief that, well, if the government makes it legal, it can't be that bad for me, right? So this legitimizing it and decriminalizing it has led to this kind of perception of safety threshold. After all, it's a medicine, right? So your state has therapeutic cannabis and 38 states do. And so if it's a medicine, it must not be that bad. See, kids, they don't remember the days of like Oxycontin and Xanax. And like we've already learned through history that simply because something is a medicine doesn't necessarily make it safe and oftentimes makes it less safe. But that has led to this kind of conception that the drug is safe. No one overdoses, right? At a time in which we talk ad nauseum about the opioid epidemic and our concerns around overdose with opioids, this idea that no one overdoses on cannabis and THC kind of like separates itself, and the reaction to that is, well, it must be safe if you can't overdose. I have studied this intently about, okay, because people want to challenge this, like, well, no, people do overdose on it. There has only been one death certificate that has been filed that has reported acute physiological toxicity caused by THC. There's just been one, and it was in Louisiana a few years ago. And since then, a number of pathologists have come out and said, that probably wasn't accurate, right? That coroner, that pathologist kind of stood out on its own, and there hasn't been another one. So generally, it is assumed that it doesn't possess that acute physiological toxicity. You can't overdose on it. People obviously have adverse reactions. Some of those we'll get into here in a few slides, but you don't have that overdose potential like you do with an opioid, like you do with alcohol and some of these other drugs. It's not addictive. This is, as I mentioned, these are true, and this is a bit of a half truth, right? It depends on what camp you decide to reside in. 100% cannabis has what we call psychological dependence, behavioral dependence. If we have clinicians who practice in addiction, you'll understand this. And for those who are not practicing in that, there are 11 symptoms for addiction in the DSM. 9 of them are behavioral, 2 of them are physiological. And the last 2 are about tolerance, enzyme induction, and then dependence with withdrawal. We know that it has significant psychological dependence. Those first 9 symptoms can be there. There's a controversy on whether or not people can build a tolerance and thus develop a physical dependence to cannabis like people do with alcohol and opioids. So the jury's still out. I tend to be on the side that we don't have enough information to suggest that you do have enzyme induction, which then builds tolerance, that then breeds to physical dependence. So this notion of it not being addictive has led to that this drug is safe. My very favorite excuse to why this drug is safe is that it's better for you than alcohol and cigarettes. And that's what Abby had specifically targeted. And the reason I love this example is that you could have picked a drug that had a bit of a higher safety threshold than alcohol and cigarettes. Most people don't realize, or they fail to realize, that alcohol kills about 95,000 Americans every single year in this country. Not from overdoses, but what we call chronic physiological toxicity. When we think about the 3 deaths of despair, the reason life expectancy continues to go down, we have suicide, we have drug overdoses, and then we have, alcoholism or disease of the liver, cirrhosis of the liver. And so to tell me that something is safer than alcohol isn't really telling me anything, right? Like cocaine is safer than alcohol if we're just talking about a safety threshold. And so this is one I always push back on. And cigarettes, I mean, that kills half the people who use them chronically. I mean, that's the most dangerous drug on our planet throughout history has been cigarettes. And so to tell me that something is safer than either of these 2 things isn't telling me anything at all. But that's what's leading into this belief that the drug is safe. So when we look at North Dakota specifically, I wish you guys had some more updated data. I was searching and trying to find out because you have some good stuff out there. It's just now 4 going on 5 years old. But there was a survey that was done in 2020 that looked at risk perception. And you can see here that in North Dakota, that only 45% of your young people believe there's only slight or no risk to consuming cannabis. That's problematic. If half your young people don't see any risk or very little risk in its use, you are going to see your trend. Once you make it more accessible, you're going to see it tick up. I point out the prescription drug one as kind of a call of hope, right? So if we went back 15 years ago, you would have seen that prescription drugs had a very low risk perception as well. But we have then, through the opioid epidemic, really promoted and pushed this idea around prescription drugs being dangerous. And you can see now that that's paying off dividends in your state, where now 55% of young people see great risk in using and abusing prescription drugs. So There's hope we can do it, but right now, if you were to ask me like what's going to happen in North Dakota once you make it more accessible, you're going to see an explosion of use among your youth because they don't think it's bad for them. They have a low risk perception. And that's where we have to correct it, right? Because is cannabis safe? And it's a two-part answer, and I'll give you the very brief part first. If any of us on the call want to use cannabis as a healthcare professional, I have very little concern. As long as you don't get behind the wheel of a car and smash into my family. But if you want to sit home and you want to use recreational cannabis, I don't particularly have a huge adverse reaction to that. Um, but you all are adults with fully maturated brains. Our largest concern, and should be our largest concern as a healthcare field when it comes to the legalization of cannabis, is what it's doing to our young people who have underdeveloped or not yet fully developed brains, right? So we generally kind of agree that the brain is fully maturated at about 25 years old. I get there's some tales on both ends of that. But up until that point, you are not who you are going to be. And what we know about cannabis, and specifically THC, is that it changes the neurology of certain regions of the brain when it is introduced, right? So when it overactivates neurological activity in specific regions of the brain, we're talking about changing neurological pathways potentially forever. Now, I don't mean the sky is falling and the kid who tries it once is going to have this lifelong challenge, but we know that when we start to introduce these drugs to these regions of our brain, that there are going to be long-term consequences. For you and I, we're going to have these consequences when we're under the influence of the drug. Once we're not going to have those consequences. But for young people, these are the consequences that we know of, that research very clearly points out that we are going to have. So we're going to have difficulty thinking and problem solving, problems with memory and learning, difficulty maintaining attention. I don't know about you all. I teach college freshmen in one class. They don't have a lot of capacity to lose any more attention. So anytime we're talking about delaying that or reducing that, we're talking about significant challenges and problems, right? And so the result of that, how this happens, is that we are overactivating those the THC receptor sites in those regions of the brain. Because this is a mental health forum, right? Pediatric mental health, I wanted to kind of drill into this more specifically. This is where a lot of that misinformation comes from, and it's been my colleagues in the therapeutic side that have allowed some of this narrative to be created without pushing back. And we know empirical evidence is very clear that when young people are using cannabis, it is linked to increases in depressive and anxiety symptomology, right? So this is a drug that is increasing those mental health challenges at a time in which these kids are already stressed out and sad and depressed as it is. And so this is a drug that is making it worse. But if we go back to that belief that it's a medicine, we have created this narrative that cannabis is this great anxiolytic drug, right? People say, I take cannabis to reduce my anxiety. That's not what the science says, right? Like that, it might work for you individually. I'm not saying if you use cannabis and it reduces your anxiety, that's great. But for the general public, it is going to increase anxiety, particularly after you use. And the analogy I like to draw is alcohol is also great at reducing your anxiety, but we don't promote its use as an anxiolytic because we know that after drinking, that anxiety gets worse. We've seen this huge increase across emergency departments in Minnesota, but also across the country, and where we're bringing young people in who have substance-induced psychosis. So they are using, they're not smoking ditchweed and getting psychosis. They're using high-potency marijuana. They're using those vape cartridges that in some instances have 90% THC in them. Most strains of cannabis, even the ones that are like that they're like manufactured or designed to be used for getting high, they got like a 30% THC. Those concentrates, those cartridges that people are vaping with oftentimes have 80, 90% potency. So that kid is hitting that vape 2 or 3 times. It's like smoking 3 joints in one sitting. And now they're having those psychotic like episodes that land them in the emergency department. We're back to that psychological dependence. The younger somebody starts using a drug, the more likely it is that they become dependent on it, right? So I don't believe in the gateway theory, which means a certain drug equals another drug. But the one I absolutely subscribe to is that the onset of use is predictive of who becomes addicted or meets that diagnostic criteria for addiction in the future. For you prescribers on the call, I just wanted to add one slide here. It's its own presentation, but just very briefly an overview. We know that there are significant negative interactions with prescribed therapeutics and the use of cannabis, and so it's really important to understand, how much of this drug your patients are using if you're prescribing medicines within these categories, because there's going to be a negative interaction, or at least the American Pharmacist Association, this is the trumpet that they are sounding. Like, you have to make sure you're monitoring these indications between these two substances. So beyond kind of the health consequences, we know that there's a significant school performance consequence that comes with this. It's about age. So we use IQ, which I understand is not a great measurement. People don't like it, but it's a standardized one. And we know that children who start using cannabis, particularly before 18, often have a significant reduction. This study has been done over and over again, and it's kind of agreed upon that they lose about 8 IQ points. IQ is not about intelligence, it's about aptitude to learn something new. And so we're talking about young people becoming young adults and older adults who don't have the capacity to learn new skills. That's problematic for society. The other thing I want to just briefly touch on that I feel compelled to anytime I talk about cannabis is that belief that it's safe, and even the truths behind some of its safety threshold get lost when we start talking about synthetic marijuana. So this is not the same thing. Synthetic marijuana has nothing to do with, organically occurring tetrahydrocannabinol delta 9. It's these drug creators and dealers have essentially stolen the word marijuana because people think it's safe, and they have just created a man-made drug that often has significant consequences. So like in Mankato, where I'm from, we had a fatality of a young 16-year-old, a sophomore in our high school, who was what she thought was purchasing cannabis, and it ended up being a synthetic blend of cannabis, and it caused a fatality. And so this is a growing phenomenon. And so when we're talking about educating young people about the dangers, we have to have this conversation alongside the conversations about what real marijuana is doing. And so this is scary stuff. As a father and as a clinician, like this integration of these synthetic drugs into what we kind of recognize and these drugs that we understand or believe that we have a good understanding of. And these are often drugs, just last thing about this, these are often drugs that aren't even illegal. Like, these are drugs that you can purchase at these smoke shops. If you go into your local smoke shop, yes, you're going to see the pipes and you're going to see the packs of cigarettes, and then you're going to see these like supplements. That's how they're sold. They're not sold as a drug because those are regulated. Supplements are not regulated. And so they're sold as supplements, and they're these things like Scooby snacks that promise these psychoactive effects, but we don't regulate them. And they often have pretty damaging side effects that go along with them. So ensuring that we're having that conversation. The other conversation I don't have a slide for, but just want to plug here, is behavioral toxicity. So yeah, you're not going to overdose on cannabis, but if you use cannabis and get in your car, you're going to see an increase in fatalities and toxicity related to behaviors. So car accidents, falls are things that we see increases with anytime we see an increase in use. So it's not just about warning people about the health consequences to their body and their physiology, but also their behavior, which then can cause all of these other challenges as well. So let's talk about prevention, and then we're going to get into our case study, because I wanted to make this as interactive as possible, so it's not just me talking or lecturing at you for an hour. But oftentimes we feel helpless in what we can do with this topic, because after all, I don't think we have any legislators on the call, right? Like we're not in charge of whether we legalize this or what the rules are around it. And so we then kind of just throw our hands up like, I guess there's nothing we can do. And I challenge each of you that there is, that we can do a better job of preventing adolescent use when it comes to cannabis because we've done it already. We've done it with cigarettes. We've done it with prescription drugs. So I know it's in us that we can have these conversations and reduce this drug trend. Because I fear if we don't, it's just going to continue to rise or remain static at a level that is unacceptable, at least by my standards, the amount of young people who are using cannabis. So it's on each of us to really grab that education by the horns, right? The prevention education and changing that narrative that this drug is safe. Every conversation I try to have with young people isn't about shaming them for using cannabis. It isn't centered around misinformation, like telling them that cannabis is the devil's lettuce and that they're going to turn into, losers in the future if they use it. Like I don't go that route. If that works for you, you do you. But for me, I like to give people the facts, like give them the actual information about what is this drug doing to them today and ultimately what is it doing to them in the future, because sometimes like youth don't really well, they think they're invincible. At least I did when I was 18. That's why I joined the infantry in the army, right? Like I just didn't think anything was going to hurt me. And so that sometimes in that moment isn't going to dissuade them from use, but when you start connecting it to things like if you're using cannabis in middle school and high school, it's going to impact you when you want to go to college and when you want to get your career set up because you are going to have a decrease in your ability to learn new skills. So it's that, what are the health consequences to change that narrative that this drug is safe? I also think it's time for us to screen for cannabis use no differently than we already do for things like alcohol use. Many of your clinics and organizations use audit screening, the alcohol use disorder identification test. You probably use the PHQ-9 to screen for things like depressive symptomology. We have to get socialized and just comfortable with the fact that because of how prevalent this drug is now and will become in the future, that we need to ask about it. We can't just assume that they're going to tell us, oh yeah, by the way, I use X amount of THC every day. The last bullet point often gets me canceled, but I'm going to say it anyways because I'm a big promoter of science. And we got to get back to this notion of family values and this idea that parents matter. And again, I did this presentation on Monday to the Social Work Association of Minnesota, and I had some pushback, but then I show them this slide. The evidence is overwhelming that parental involvement is the greatest protective factor in basically every negative social outcome you can think of, but specifically with drug use. The more involved parents are in their children's lives, the less likely they're going to struggle with drugs, the less likely they're going to have teenage pregnancy, the more likely they're going to graduate high school. You can basically pick every bad thing, and the more involved parents are, the less likely those things happen. So I just like to remind people in that prevention that it's not just talking to young people about this issue, that it's involving parents, it's involving the family, and just pushing parents to get more involved with their young people. Again, sometimes gets me kind of canceled a little bit in certain places because I don't know why family values has this negative thing spun to it, but I'm a big believer of it because the science tells us this works. All right. Let's do a case study because there's about 20 minutes left, and I'm a little bit over on my lecture at you all, but I want to open it up to kind of some, not only questions. I want to save some time for that, just more general, but to really utilize what you've learned here, but also your experiences in addressing this case. So I will read it because some of you are, multitasking. Dr. Johnson, a family physician out in rural North Dakota, recently reached out to you to consult on a 15-year-old female patient, Kennedy. In her most recent appointment, Kennedy's mental health screeners identified that she was experiencing symptoms of both depression and anxiety, which represent a change since her last visit. When asked about the symptoms, Kennedy reported that she's been feeling off for a few months. She goes on to report that she's been using a vape pen with THC cartridges to deal with her emotions. She reported reading somewhere that medical marijuana is helpful for anxiety. That's our fault. That's our fault. And it was easy to get at school, right? She reports feeling better while using the pen, but worse afterwards, which prompts her to continue this cycle of use, right? I feel good using it. I'm just going to keep using it so I don't have to feel bad. So Dr. Johnson, who self-admittedly isn't very familiar with the impacts of THC or its addiction, is hoping you all can provide some insight in how to interact with Kennedy, and I even want to expand it out to maybe Kennedy's parents. So that's the case. What are you doing with this situation? And so if you want to unmute, that's probably the best way to kind of just chat. But if you dump it in the chat, I'll read this out. I'll read it out loud as well. Oh, I teach freshmen. I'll remind you, I can sit here all day in silence if you need to. Anyone want to comment on Dr. Johnson here? Or maybe share a case that's maybe a little bit different, but is similar in that requires some information to be shared with other providers about cannabis who may be less informed.
Hi, this is April. I work in infectious disease, but my biggest thing, and I have a 15-year-old son, but my biggest thing with this too is to know how much the parents of this patient actually know about the drug, or are they users themselves? That would be my biggest thing to want to know, I guess, or how they came about even wanting to start this.
Yeah. Thank you, April, not only for just being first, but your perspective on that. I think those are great questions, that I would be asking, like, okay, what led you to cannabis? Is it truly that you read somewhere that it's going to help you with how you're feeling, or was there peer pressure? What are the messages you're getting? And then ultimately, what would mom and dad think about this? Because if the answer to that question is mom and dad are supportive of it, or mom and dad are the ones who are providing me with this vape cartridge because I report to them that I don't feel well, it changes the whole context of the case. Now we're talking about having to bring in mom and dad and having that psychoeducation with them as much as it is with Kennedy. So some great perspectives there, because you're absolutely right. We unfortunately often see this kind of effect where if mom or dad or caretakers are users of substances, that we have this increase of use among their children. And that has to just be tackled head on, I think. So thank you, April. How about others?
Hey, Thad, good to see you here.
Yes.
It's Jen. I would share this video with Dr. Johnson. Sorry. But then I would go back to the part about why it works in the moment of using, the impact that it has on the brain, and then educate that, but then also educate why it feels worse afterwards. And then because I'm behaviorally health trained, I'd go back to the emotions she was having of anxiety in the first place and work towards skill development. So the use or anticipated need of using marijuana or anything else in that matter could be alleviated by teaching skills towards the anxiety.
Couldn't have deconstructed the case better myself, Jen, and I wrote it. So thank you for that. I think you touch on a few things that I wholeheartedly support, and that is just being honest in education, right? So you're not saying, hey, this drug is making you feel worse. You're talking about like, okay, what's actually occurring so that young person will have the facts about why she might feel worse after using and why she's then drawn into using more. And I love the idea, and it might not be Dr. Johnson, whose responsibility and role is as a family physician, but might then refer to someone in the community to deal with those emotions that were occurring pre-use. So how do we tackle those anxiety symptoms? How do we tackle those depressive symptoms so that maybe there's another alternative to utilizing THC in the meantime? And so, yeah, I absolutely think those two things, giving that real-time, real-world education, and then also that what do we do with it? It's not just you can't use cannabis anymore. It's this is what you need to do then to address those behavioral health symptoms. So excellent there. Thank you. And great to see you again. So we have Dr. Rowling here. I believe she is working with the patient. Start with praising the patient, right? Yeah, the initiative that she took to help with their mental health, and then talk about that it would not be our recommendation for treatment due to its side effects. So yeah, I love that motivational interviewing, like not trying to shame her, bringing her, praising her for that, wanting to take responsibility for how she's feeling, but then educating her on what might be a more appropriate course of treatment long term for how she's feeling. So yeah, I think if Kennedy was my daughter, I would say that's exactly what I would hope my family physician would do with my daughter. So thank you for that, Dr. Rawling. Other thoughts on this, or I suppose we could also just open it up for, I'll touch on this. I never do a presentation where I don't give people something to take with them. And so when you have the PowerPoint here, you'll be able to kind of access. There's tons of information out there. These are just some trusted sources that I have about how to have these conversations, both with patients and their parents. And so, but ultimately, I want to open it up for questions here and opportunity just to have a more larger conversation on this topic with our remaining 12, 14 minutes or so. So the floor is yours to either go back to Dr. Johnson or to just engage with one another in some questions. Well, as folks are waiting, I can, I guess with this remaining time, speak just a little bit to what we have seen in Minnesota. I know we have folks probably on both sides of the border here, but we have some concerns, right? We legalized cannabis last year, so it was August 1st of 2023 that we decriminalized and legalized possession and use of cannabis for adults. We set the age at 21. There was some push from certain pockets of advocacy groups to put that number at 25, which to kind of correlate with that fully maturated brain. But our legislature said, no, if you can buy a beer at 21 and a cigarette at 21, you can buy your pot at 21. So the concerns we're now having really revolve around what will retail sales look like. There's a lot of conversation about where they're going to go. I do this presentation a lot for municipalities that are kind of identifying their own rules within their community. And in every community I go to, I measure how close their high school is to their closest smoke shop, which will likely become their dispensary. And the winner of that in Minnesota, or maybe the loser, depending on how you look at it, is Staples High School, which is only their front door of their high school is 67 feet. It's literally across the street to their likely dispensary site in their community. And so you should have seen the look on those council members' face when I said it's 67 feet from the front door of your school to where you will likely be selling cannabis. And so a lot of our concerns right now in Minnesota have to do with that upcoming shift and allowing retail sales, because we're going to see this increase in accessibility. So yeah, I think that's a big concern that we currently have. Our therapeutic program, I know North Dakota has one of those as well. We don't have medical marijuana. It's a long story. It was a big fight in our legislature. We have therapeutic cannabis program in Minnesota. And essentially, we're kind of just waiting for retail sales to get online because it will kill that program for the most part, because at that point, you're not going to pay the prices that are currently in place for that, what we would consider pharmaceutical cannabis, when the retail sales will often be much less. So people won't need their card, need to be enrolled in that program to then just self-medicate with it. So speaking of its use as a medicine, I know we have some prescribers on the call. For psychiatry purposes, I'm adamantly against it. I think the research is mixed at best and probably more so against the use of therapeutic cannabis for disorders like anxiety disorder, depression. Post-traumatic stress has the one where I would say has the most of the mixed results. But here's the thing, we don't have any standardization around dosing. We don't have any standardization around frequency of use. It's the Wild West, and at least it has been in Minnesota for the time that I've been involved with therapeutic cannabis. We just don't know what we're doing, and I don't think that's a good way to practice if we're calling it an intervention. So, anything else? I was expecting some more interaction. I have to be honest. I was told don't lecture at them for a whole hour. They're going to want to talk. So, anything else that you all have, questions, concerns, thoughts about this topic?
What's the screening tool that you would recommend for use?
Yeah, that's a good question. I wasn't prepared for that one.
Well,
You
I bet
know,
you easy that.
yeah, right. I don't know. I would probably look at the National Institutes of Drug Abuse and see which ones have been, depending if you're talking about a general screener for your pediatric patients all the way through your geriatric patients, kind of like what you do with the audit, there's probably something. If you are working exclusively with pediatrics, I would try to find one that's been normed against that population. So I would go to the National Institutes of Drug Abuse, where I have found, in my experience, to be the most reliable source of this data. So if you're really wanting to know, email me and I promise I'll look it up and send you one. But I still think there's a lot of work that needs to be done in those assessments because we just haven't been doing it. It's not something that's commonplace.
I wonder if there's going to be like a new craft and with the nicotine added, if we could do
Sure.
one like the marijuana
Yeah.
ad, commonplace substitute.
Yeah, or if anyone's looking for a dissertation topic, if we have any doc students out there, we could work together, develop our own, right? We can make our own screening instrument for that. But even beyond screening instruments, I think we sometimes overcomplicate some of these conversations. I just think we have to just get in that practice of just asking even young people who don't maybe appear to be drug users, right? Because I think there is this stereotype of like, we're going to ask the person who looks like they should use drugs or, their behaviors are drug using. We just have to ask everybody, like, what is your cannabis use? Not because I'm going to shame you, but because I'm also prescribing you Zoloft, and we know that there's going to be some interactions with that could potentially be negative. And so it's just getting into that habit of having that conversation and asking that question. Anything else? Well, stay tuned for Minnesota. You guys are in a good position. I don't know where it's going to land. I was asking Nikki at the beginning if you all think it's going to pass in North Dakota or not. I shared earlier in my research, North Dakota is the only state in the country that when they put this measure on the ballot, that rejected it. Every other state that asked its people if they wanted recreational cannabis voted for it. You're the only one, as at least that I'm aware of, that rejected the ballot measure. And so it's coming around for round two. And what I meant by like, you're in an advantage is that you will get to have now seen 24, 25 other states who have gone through this. And one of the things that when I was a part of some advocacy and advisory panels for our program, our recreational program, I've said, let's use the lessons learned in Colorado. Let's use the lessons learned in Washington, who have now had this program for more than a decade. And let's learn from what they did to ensure that our program maybe doesn't have some of those same challenges and side effects, if you will. And so I'm hopeful that if North Dakota, if you all decide this is what you want to do, that the people who get to make the rules, the people who are going to set this program up are consulting with people like you. Because again, this conversation needs to be driven by actual science, not political science. And in Minnesota, I would argue that this was a political science decision and not one that spent a lot of time talking to us in that conversation. Okay. Well, if there's nothing else, so we don't have to sit here just to sit here. And so, Nikki, I'm going to turn it back over to you and thank each of you, for your time this afternoon. If you would like a copy of this, it sounds like Project Echo is going to make sure you all have this presentation. There's nothing proprietary in here, so please utilize this to any way that you would like. And if you have questions, concerns, comments, you can just reach out to me directly. I'm easy to find and happy to engage in conversation, and hope to be with you again in the future on one of these things, on some of the other projects and work that I'm doing. Otherwise, I'll see you around, right? It's a small world out there. I'm sure our paths will cross again. So thank you so much.
Thank you so much, Thad. Appreciate that topic and all the information. So yes, everyone should be getting an email, and please remember to fill out your evaluations to get your CEUs. So thank you.